So years ago at the general surgery residency graduations, it became clear to me after repeated years that despite my best efforts, the general surgery residents found me very intimidating, and so I just decided to embrace it, just bad to the bone. When I discussed the title of this talk, Cutting Edge or Unkindest Cut, one of my colleagues said he wasn't really familiar with the term unkindest cut. And for those of you that don't know, this was a term that comes from William Shakespeare. In Julius Caesar, Marcus Antonius refers to, "For Brutus, as you know, was Caesar's angel. This was the most kindest cut of all." And he was referring to the assassination of Julius Caesar by his good friend Brutus. And so the unkindest cut refers to, in generally, a public insult, affront, or offense, often so painful because it comes from a trusted friend. And I consider you all my friends, so I hope what I say won't be perceived as unkind or offensive. So we have amassed a bit of experience with outpatient ambulatory surgery, and I have to acknowledge the work of Dr. Rob Bray, who severed his relationship with Cedars and basically all inpatient hospitals over a decade ago and established his own outpatient surgery center where we did these first procedures back in 2008. And he continued to do these procedures along with our assistants for many years. And as you can see, there's been quite a sharp uptick in the last few years in interest in this outpatient surgery that we've been involved with. And by we, I mean primarily my partner Raj Rao and me. Back up a bit. And interestingly, around 2011, 2012, Rob Bray was at one of your national spine meetings, and one of the surgeons there that was touting the benefit of the Transone screw and saying how great it was because it didn't require the assistance of somebody like me, a vascular access surgeon, but more importantly, it could be done in an outpatient setting. And Rob challenged him and said, well, we do these procedures in outpatient setting all the time, 5-1 ALIFs. The surgeon was aghast and said that cannot be done, which was sort of ludicrous because at that point, we've been doing them for many years. So in our experience, we've actually at this point now done 336 outpatient anterior lumbar spine operations with relatively little morbidity. There have only been, to my knowledge, 2 readmissions. One was a stable hematoma in a patient who presented to the emergency room the night after surgery with some abdominal pain. And we admitted that patient and he did fine and actually went home the next day. And another patient that came in several days later with a post-op symptomatic lymphocele that resolved with percutaneous drainage. One patient recently, actually just within the last month, developed a post-operative bleed that had to be returned to the operating room due to a middle sacral artery bleed where a clip had come off, but there's been no mortality. Little heavy-handed on the clicker. So what are appropriate procedures to be done in the outpatient setting? Well, it's sort of a slippery slope. We started out doing only 5-1 disc replacements and ALIFs, and then 4-5s, and now I would have to say I'm pretty comfortable doing 3 levels. I'm not sure that I would tackle 1-2 or 2-3 as an outpatient, but who knows, maybe 5 years from now I'll be coming back and talking to you about our experience with those. I think you can certainly get to any level, lumbar level laterally as an outpatient. And Dr. Rao, who has a lot of experience with oblique exposure, is doing these procedures at 4-5 and 5-1. So the contraindications, who shouldn't we be doing this on? Well, certainly anybody who needs a redo anterior exposure. These are very formidable operations that require the input from a lot of specialties. We routinely use ureteral stents when we're going back on the same side, has markedly increased vascular risk. Big question mark about the role of BMI. Some outpatient surgery centers in general don't allow patients with a BMI over 35. I think we've skirted that issue a couple times and have not had any problems, but certainly patients with higher BMIs do have higher risk of bleeding complications. I don't see pre-existing vascular disease as being a contraindication. We certainly operate on many patients with occlusive disease and aneurysms, and that's not a problem. But as I noted before, I don't think you should do L1-2 and 2-3 because I think those patients, primarily because I think those patients have a much higher risk of ilias, prolonged ilias after the operation because of the need to mobilize a lot more of the retroperitoneal structures and the bowel. So I would be a little reluctant about doing 1-2 and 2-3. I want to reaffirm a very strong belief that I have that access surgeons such as I, and I actually learned this at Texas Back from going down there and seeing how you guys do things. And when you're, at that point, we weren't seeing our patients pre-op, but your access surgeon in Texas said he saw all of his patients pre-op, and that convinced me, and from that day forward, I've required that I see all my patients, and I just feel so much more comfortable about it. For a number of reasons. It's very important to identify if the patient has recent history of DVT or has a hypercoagulable state. We want to examine the patient by a vascular surgeon who can establish, not because it's going to make a difference in terms of how we manage them, but it's important to document what their arterial anatomy is and to just eyeball that patient and determine whether you think you really can do this procedure safely. So we talked about BMI, but I'm referencing here a quote from Justice Potter Stewart, who in reference to a pornography case that was being presented at the Supreme Court was asked to define hardcore pornography, and his response was, "I know it when I see it." And that's true of looking at our patients. You can, as an experienced surgeon, you can look at somebody. Some people have high BMI because they're very musculature. They have very muscular, and some people distribute their weight differently than others. So what we don't want to do is walk into the operating room and see that, which is what happened to me once with a patient who didn't come in to see me pre-op. You need to be able to see these patients and talk to them. You can't give informed consent over the phone. Other issues, you guys are looking at the spine. You're looking at it and trying to figure out how can I best reconstruct the spine. But it's my job to get you there, and I know what it's going to take to get you there, and you don't know because you're sitting in the lounge while I'm doing the exposure, and then you walk in and miraculously the blades are in, the spine's exposed, and you don't know the sweat and tears that I went through to get there. You just kind of know how long it took. But I've frequently seen patients that have had prior spine surgery, and that information was never communicated to our office, and it requires a whole armamentarium of structure of consent and teamwork in order to do those redo operations. So it's important that I make sure they don't walk in the day of their outpatient surgery and find out that this is a redo. Another patient I saw recently had prior testicular cancer and a periaortic lymph node dissection with clips all the way down his aorta. Once I saw that and discussed it with the surgeon, we changed the plan to a lateral fusion. Laparoscopic hernia surgeries. The way they do those procedures is they just get into the preperitoneal space, stuff some mesh in there, and you can't even see a scar. But when I go in, that plane that I'm using is fused because of the mesh that's put in. So that also goes into the informed consent with the patient. And sometimes patients have had pelvic surgery that I didn't know about. Another recent patient, here we see the bifurcation of the iliac vessels. Another patient presented to me recently, and as I examined them, we noticed that there was this mass here in the left lower quadrant, which was the patient's kidney transplant, which was coming off of the iliac vessels and would have been directly in the path that we would have been using to expose 4 or 5. And this wasn't appreciated by the spine surgeon. Nor was this ostomy on the other patient that I saw recently who needed a 4 or 5 exposure. Because again, you guys are looking at the x-rays. Other issues are frequently, I don't spend a lot of time talking about the medical evaluation, but certainly patients have brought up issues. I saw a patient just last month that needed an anterior spine procedure, just a 5-1 ALIF. Turns out the patient had been evaluated and diagnosed with a vascular subtype of Ehlers-Danlos syndrome. Now, you probably know what Ehlers-Danlos is, but there's a vascular subtype which is rare, where the collagen in the blood vessels is abnormal, and just the mere act of retracting the vessel can cause them to fall apart, and no means of reconstruction will work because they don't hold sutures. Needless to say, that patient was approached posteriorly. That never would have been evaluated and potentially could have been a life-threatening event had we not had that preoperative consultation. And medical legally, I just don't think you can have a pre-op consultation with the patient in the pre-op area that's valid. Patients come in, they're anxious, they're not listening to anything you say on the day of surgery. I really appreciate that face-to-face conversation. And lastly, and I know this is not of any concern to any of you, but in terms of getting patients to pay their bills, if they've never seen you before, they don't really know what your role is, and you send them a bill after surgery, they're likely to ignore it, and they never have any relationship with you. If you're going to do these procedures at an outpatient surgery center, you have to have vascular sutures available for the occasional patient. The most common thing we run into is a little venous injury that requires a repair. Very easily fixed, but you have to have the right instruments. You have to have the right needle holders, you have to have the right sutures. Whenever we do 3-4, 4-5, or a transitional segment, because it requires a little bit more mobilization of the vessels, we do like to have a cell saver available. I don't think that's critical for a 5-1. And this is really kind of optional, but I do think it would be helpful to have a selection of vascular grafts available. Having said that, it's probably been at least 7 or 8 years since I've had to reconstruct a vessel because of some injury that was so substantial that we couldn't just repair it, and that's probably happened. I know that that's happened less than 5 times in my entire experience of over 5,000 anterior exposures. So it's not a common occurrence, but you just don't want to be stuck in a surgery center somewhere with no equipment. So in conclusion, I think these procedures are safe. We're doing more and more of them. We're doing more complex procedures. They certainly are cost effective, but don't compromise your standards. Thank you.